Oh, I don't get the jargon of clinical epidemiology. What is meant by internal and external validity?
Internal validity refers to the comparison within the study, whether it's fair and unbiased.
And external validity?
Whether the results apply to your general population. We speak of this as generalisability or applicability.
I've heard it said that we should apply the results of the clinical trials to the sort of patient that was in the trials.
Shouldn't we apply them to everyone?
That's a good question. There's a simple rule. If it works for one, it should work for all.
Whether they've been included in the trial or not?
Yes. The early statin trials included very few women.
Because it's harder for women to make a commitment to clinical trials. They don't have wives to do things for them. Therefore, they're underrepresented.
Yet with time, it became clear that women benefit from treatment too.
Right.
What about people with comorbidity? They're often excluded from trials too.
Yes, because they suffer outcome events which are unrelated to the study question. This is a design feature. It's to improve the signal-to-noise ratio. It doesn't mean the results won't apply to them.
So you might extend treatment to people who weren't represented in the trials?
Yes.
What about the reverse? If the trial was positive in all comers, should we apply it to everyone?
Another good question. I'd say not always.
Explain why not.
Imagine it's the early 20th century and you're dealing with the problem of anemia. Let's say you give treatment with vitamin B12 to 1,000 patients and the mean hemoglobin goes up from 9 to 11 with a p-value less than 0.001. Should you now give vitamin B12 to everyone, even as the mechanism of anemia unfolds over time? We now know that it was people with B12 deficiency who would have benefited, and they drove the overall results.
Okay, I see that.
Do you have any more modern examples?
Ideas, yes, but no proof.
Tell us anyway.
Dual antiplatelet therapy in acute coronary syndromes. I'd suspect it's only the people who get a coronary stent that really need it.
Okay, another?
Statins in patients with stroke? Stroke has many mechanisms. I doubt that statins benefit people with AF and thromboembolism, or with shearing of a penetrating vessel due to hypertension, but I do expect them to work in carotid atheroma with plaque rupture and thrombosis.
So you think you can pick who needs the treatment?
Sometimes, yes.
Then why do the pathways say to treat all patients?
So that people who might benefit don't miss out.
So how should we decide?
You can start by making a provisional diagnosis.
That's a good idea. I'll try that.